AMR on the continent. Finding outbreaks is really one of the things that genomics does really well. As even if you're not a bacteriologist, you'll know that this has been really helpful in the COVID pandemic as well. So the other thing that genomics really helps with is understanding how community-acquired infections caused by bacteria are spreading. And this is really important for containing those infections, as well as for determining what intervention should be used in a particular setting. I'm giving you an example from Salmonella. Salmonella after E. coli is probably my best friend these days. So Salmonella typhi in particular causes typhoid fever, which is a life-threatening disease. And typhoid fever is endemic in many settings in Africa. And there's been some excellent work on the genomics of typhoid fever, the cause of typhoid fever, Salmonella typhi, that shows us that different lineages are predominant in different parts of the continent. Okay, with in the east you have lineages that are believed to have come from Asia, and in West Africa our most predominant lineages are 232 and 311. And one of the things you'll see from this map, there are others, there's a follow-up paper that follows just West Africa that has a bit more data, but we still don't have a lot of data. We did have data before we started from Nigeria, from 2 sites from Nigeria, but these were both in the north and north central. We really had no idea what was happening in the southern part of the country in terms of lineages that are spreading. We now know. We now know that the 231 lineage that is predominant across a lot of West Africa is, the 311 lineage is our most important in Southwest Nigeria. These are data that were obtained from samples sent from 5 different sentinels in the southwest of the country. And importantly, we can also tell that because of the rate of sending, that Salmonella typhi is one of the most commonly recovered bloodstream isolates, period. And this is an important piece of information that we need to have nationally as we try and persuade our country to adopt typhoid conjugate vaccines. Just yesterday, I was reading a new paper from Ginny Pizza's group that was showing, that was providing a justification for vaccine introduction in African countries. And this is just one figure from the paper that shows fluoroquinolone resistance. And what you can see is that this is a huge problem in Southern Asia. And we have less of a problem in sub-Saharan Africa. And you would almost sigh with relief, particularly when you see that Nigeria, it's close to 0. But I should warn you that when Salmonella typhi becomes resistant to the quinolones, it does so in a stepwise fashion. It gets mutations in quinolone resistance determining regions one at a time. And once a strain has had the first mutation, it can move very rapidly, gathering additional mutations. It can also acquire horizontally acquired genes that confer low-level resistance as well. So if we look at the genomes of our strains, and by the way, these strains are actually sensitive. So while you can't see much detail from the slide, I should tell you that the green dots are a single point mutation, which you can see that most of our typhi, which are these peach colored at the bottom of the tree, most of our typhi have at least one mutation. This means that even though they are phenotypically sensitive and will be classified as thus, they're on the road to becoming resistant. And this is something that we can know from genomics that we wouldn't necessarily know if we're doing phenotypic work alone. I should also add that from genomics, we're able to tell that after typhi, the most important invasive non-typhoidal salmonella, at least right now in the Southwest, is Salmonella enteritidis. This is something, again, that we were not aware of, and something that serotyping is quite difficult to do in our setting where resources are limited. So it's something that the genomic surveillance program is actually contributing for national policy. Okay, we're running out of time, so I'm just going to give one more example on the fact that if you have a genomic surveillance system for antimicrobial resistance, it provides you with additional information that you can use for other things at no additional cost. And I'm returning to Klebsiella for this example. So as many people know, Klebsiella is an important cause of hospital-acquired infections, including neonatal sepsis. It would be so lovely to have vaccines against the major lineages that cause Klebsiella sepsis in hospitals in lower and middle income countries. And there are a lot of researchers that are working towards this. The information that they need is which serotypes are the most common and should be part of these vaccines. And there are global information available from select countries that show that O1 is really important. But after O1, it's not really clear what's important because different O groups are important in different parts of the world. And you see that in Africa, we see different things in different countries. And even more importantly, you see that in this particular map, there's no arrow coming from Nigeria. There were no data before we started genomic surveillance. Now that we've done genomic surveillance, and I showed you all these things about new lineages and outbreaks that we found and so on, we can easily just query our data and say, well, what O groups do we have? And then we can easily say, well, O1 is very popular, so is O2. And by the way, we have a novel sequence type that is O5 that we need to watch for. So this is information that can contribute to the vaccine development effort and ensure that when those vaccines become available, they will be useful within our setting. Okay, I'm going to end in a minute. I just wanted to let you know some of the things that I'm thinking of for the future. What do we need to do to be able to grow what we've done? What we've done is actually, I should say, very, very limited. We have very few sentinels within Nigeria. From those sentinels, we're sequencing only a fraction of what they generate. We're prioritizing blood-borne isolates, which really provide the greatest surveillance value. But there's certainly a lot that we can do with the setting that we're building now. We need to end this whole procurement challenge. Most of my time is spent figuring out where to get things that are ordered by individuals who are doing the same sorts of things in other countries from local freezer programs. They just walk to the freezer, open it, take it, and say, bill me later. Whereas I take between 9 months and a year to be able to get the same reagent to be able to deliver surveillance. This is a problem. As I mentioned, we need to grow and deepen our surveillance. We also need to do the same for our workforce. And then we need to, when we're training the workforce and thinking about how to work with them, we need to not only be thinking about the people who are actually doing the sequencing and the bioinformatics, but also the users who are using the data, who need to be, who need to receive information and gain expertise in being able to read trees and understand what it is that we're saying when we say sequence type. And then we need to develop new paradigms for genomic surveillance below the tertiary care level. What we're doing now in Nigeria is tertiary care level is Illumina sequence based. It doesn't roll out to secondary care centers, rural centers, primary healthcare centers. And so we're thinking of other mechanisms, such as using the ONT platform. We're actually piloting that at a model rural center that we work with. This is really important because available data from Asia shows that you don't have the same resistance patterns in tertiary centers as you have in primary care. And most of the patients that you have in Africa are actually managed at the primary care level. Our primary care physicians need information about antimicrobial resistance patterns if they're going to be able to optimize care. I think genomics, I think we've just scratched the surface of what genomics can do for us. I think it represents a truly leapfrog opportunity, and that once we get fully standing on our feet, we will find other ways to use genomics to enhance the surveillance of antimicrobial resistance. And I'd like to stop now because I really want to take as many questions as is possible and get feedback from all of you. Thank you for staying to listen. I want to thank our funders. In particular, our genomic surveillance within Nigeria is supported by the UK National Institute for Health Research through a global health research unit for genomic surveillance of antimicrobial resistance. And I'd like to really thank the collaborators who are on this, who are part of this. I want to thank the Nigeria Center for Disease Control, which is our partner in surveillance in general and genomic surveillance in particular. We're not a national coordinating center. We just perform a reference lab function within the surveillance system. I'd like to thank all of those who work with us for genomic surveillance and to build capacity, not just in the genomics, but also in the basic microbiology because it really, the quality of what we can do depends on the quality of initial data coming out of the sentinel sites, which also need to support their patient care with antimicrobial susceptibility testing. I'd like to thank those members of my group who are directly involved with genomic surveillance. There's quite a few of them. They've gained an enormous amount of expertise in a very short time and have an incredible level of responsibility, even though they're so young, with informing genomic surveillance within our setting. And I want to thank all of you for your attention, and I'm happy to take any questions that you might have. Thank you very much.
Thank you so much, Professor Ruka, for that insightful and very interesting presentation. Thank you so much. You covered a lot of the areas, specifically, the challenge and the future directions and the opportunity to leapfrog genomic surveillance in Africa. I think those are really, really insightful points. Thank you so much. We have a few questions that are posted on the Q&A. Maybe if you can address those questions on the Q&A, and I'll try to pull some of the questions on the chat box.
Okay, thanks, Sophonias. Yeah. So yes, I have a question from Abraham Alabi. Any experience to share in setting up AMR surveillance and stewardship in small and medium hospitals and health centers in rural parts of Africa? Really interesting question. So, we, a couple of years ago, actually had the ambition of doing genomic surveillance at a rural site. And so what we did was we set up a rural pilot site. The plan was to use nanopore-based methods. We have several that we want to try out at this center. The first thing we had to do was actually to put basic microbiology in place, because we want to be able to benchmark what we're doing against what is the current gold standard. So all I can tell you right now is that the basic microbiology is working. Our staff have been trained to do nanopore, and we're about to start implementing some of the strategies that we've planned. Essentially, we're waiting for a nanopore delivery. This is unfortunately going to be the answer to many, many future questions along the line. And then I think we have to think more generally about how to get deliveries to a rural lab. Of course, we can help by having the things delivered to us first, and then we bus them over there. But that is going to be a huge part of figuring out what will work. At the secondary care level, we don't have any firsthand experience, but I should let you know that NCDC is piloting surveillance at the secondary care, and we have offered to provide some sequencing with that. And so while I can't answer the question right now, we're hoping that within a few months we'll have preliminary answers to these important questions. I should also say that we are not the only ones trying to do this. I know a number of people around Africa are buying MinIONs and so on, and trying to figure out how best to do this in rural centers. So the answer may well not come from us directly. It may come from any one of these other groups. And we are trying to talk to each other and learn from each other. Okay, there's a question from Olaiton Aware that I don't quite understand. How the activity of the enterobacteria is determined. Understand whole genome sequencing. I'm assuming, I could be wrong. I'm assuming that the question intended to ask how we know about the expression of resistance. So the most important thing you need to take away from here is that we're using genomic surveillance to make our surveillance system functional, but our surveillance is not based on the genomic data. Our Sentinel labs are collecting phenotypic data using disk testing, as Sentinel labs are doing all around the world. Every time I tell people we're using genomic surveillance so that we can have a surveillance system, they immediately presume that we are using it instead of phenotypic testing. No, we're using it to provide reference lab services that support the phenotypic testing. However, in doing so, we have observed that most of the time, not all of the time, but 90-something% of the time, the genomic interpretation and the phenotypic interpretation agree 100%. And this is one of the things that we're using going forward to justify the idea that we might be able to do genomic surveillance without culture at a rural setting. If I've misread the question, if you could put it in the chat, and if we have time, it would come back to Mr. Fonias, that would be appreciated. Now, a question from Andagachu Mulu. How do we manage the supply chain? We don't manage it. I should just say that. We're currently in a situation where we're constantly using ad hoc issues to patch over our poor supply chains. And when we find a pathway that works, then we will carve that in stone and it will be the pathway. So the good thing is that things that have failed, we're learning from them. We're actually documenting our failures. So we're hoping that people who come, who are setting up genomic surveillance after us will not have to relive our mistakes. But we don't yet have a solution to this. The good thing is that the sequencing companies now have been made alert to the fact that we actually do sequence in Africa. And we are clients from which they could make a lot of money from, and they are responding. Perhaps not fast enough for me, but they are responding. So the supply chain landscape is changing, hopefully for the better. But we don't have solutions to many of these problems. As we have them, we will share them. The other good thing is that they're actually experts in supply chain issues. We have now started talking to those experts. This is not something that Irukai microbiologists can solve. This is a larger problem that needs to be solved by supply chain experts, and they're on it too. So I'm hoping that within not too long a time, hopefully within the next year, we will be able to have this problem sorted. And apologies if you're going through the same struggles as we are. Question from Samira Sinochi, very good. What about the One Health approach? Thank you. I was going to actually mention something about this. So thanks for bringing it in the Q&A. So when we started our surveillance system, very young, we actually started with the human side. I guess everybody does that. We human beings love ourselves. But Nigeria's National Action Plan is very One Health focused. And so in the animal on the animal side for AMR and in the environment, there are plans for moving towards better surveillance. Animal is right behind human at this point, and including genomic surveillance. So it's closer to set up, but it's in the plan. That's probably the best answer I can provide at this point. I should also say that through Seek Africa, we're providing genomic surveillance services for other countries on the continent that don't have their own resources. And we actually find that the applications that we get to Seek Africa, we get more from the animal sector than from the human sector, which emphasizes the importance of a One Health approach to genomic surveillance for AMR. Thank you for that question. James Otieno.
Asking for any lessons from COVID-19 on AMR.
Yeah, so I can see, I was just reading, any lessons from COVID-19 on AMR surveillance? First of all, COVID-19 has shown everybody how important genomic surveillance is. All those people who used to lambast me in meetings saying that genomics was this white elephant that we shouldn't be implemented in low-income countries have disappeared. They can now see, I mean, the people doing SARS-CoV-2 surveillance in Africa, people like Tulio and Christian Happy have done such a wonderful job that we can see that genomics, our genomic surveillance is the best in the world, in my opinion. It's identifying new variants faster than other world regions. So it's been shown, one, it's really useful, and two, it's doable in Africa. So that's one thing. The other thing is that the COVID community is helping now to deal with these supply chain issues because they're having exactly the same issues that we are. And now we have a critical mass of people who are making complaints. And when one person is complaining, it sounds like a whisper. But when everybody is complaining, then it becomes a big thing and it actually gets on the table. And then thirdly, I should say a lot of people are learning molecular biology and genomics through training courses through SARS-CoV-2. If you've got that expertise, it's not too hard to then, step over and start doing bacteria. So I think we're getting a lot from it. It's true that we're seeing a lot of emphasis on COVID, but I don't necessarily think this is detracting from AMR surveillance. I think this emphasis is actually emphasis that would not exist if COVID had not happened. So I think it's actually adding to progress on genomic surveillance. Molly Vigas is asking, how do you use this information to inform clinical diagnostics and treatments? So the whole object of having a surveillance system is essentially to get data that would allow when a revision in the next revision in antimicrobial treatment guidelines in Nigeria, for example, will for the first time have surveillance information to go on. We will not just be using WHO recommendations for countries that have no surveillance. We will take our own surveillance data and use it to update our own plans. Before that happens, our sentinels will get information about what we're finding, and they will know what to do in their institutions differently from the national treatment guidelines because they have local lineages that are circulating. So while I'm saying this with some pride, I will also add that we are far from where I would like to be. These outbreaks that we're identifying, we need to really identify them in real time. I think it's such a shame that most of our outbreak work is actually retrospective. We're getting close now in that if somebody has an outbreak in play, they can contact us, sending a strain set, and we will sequence if the reagents are on ground. But we're not quite there where we've been able to return data in time for people to intervene in an epidemic. And that's what we're really working towards. It's a bit of a challenge. I showed you my crew. All but one of them is actually a postgraduate student. So they're doing their PhDs and masters on the side, and they're providing genomic surveillance for a country. So it's going to take some growth to get there, but it's really where we would like to be, is to be able to provide data that is more actionable. And then finally, I should say that we are training our collaborators at Sentinel sites to be able to interpret data. We're actually grateful to Phage for a grant that helped us to do the first iteration of this, because we feel that if they can actually interpret the data right as it comes off the bat, then we will also be able to close the time between generating data and being able to use it. How do we ensure sustainability? This is a question from Dana Itani. How do you ensure sustainability of sequencing and political advocacy to support implementation? Really important question. The very first thing we needed to do, and I think we're at the point now where we're doing it, is to be able to show that this is worthwhile. You can't just walk up to a policymaker and say, look, I think sequencing is cool. We should be sequencing in our surveillance system. We have to be able to say, if you sequence, we will be able to do this really important thing that we haven't done before, and at the same time save you money. And so I think having these use cases, such as we're generating in Nigeria now, and I know Africa CDC is looking at use cases across the continent, is going to be really important, a really important part of getting policymakers to engage directly and want to be able to actually fund the cost of sequencing. Buying robust machines when we do have extramural support is important, because then they wouldn't have to make that upfront cost. So we always have sustainability in mind. And obviously training the next generation is key, because they're the ones who are going to implement this at a large scale. How is adequate quality control achieved, and what are the challenges faced, and what are the solutions that we have procured? Fantastic question, thank you. So when we set up our surveillance system initially, most of the issues we had that made some labs have to wait to come on board or not yet be ready to come on board in the surveillance system were quality issues. So NCDC centrally is providing a lot of quality advice and support. We found that when we started the surveillance system that none of the labs actually had a good access to proficiency training. NCDC has taken over the responsibility of ensuring that our labs have connection to proficiency training materials, including us. We couldn't get proficiency training materials into, proficiency testing, EQA. We couldn't get EQA materials into the country. So NCDC helps us with that now so that we can have EQA done. We have our in-house quality assurance. But as you know, if you're doing genomic work, there are not that many options for quality improvement. And I'd also like those who are working directly in clinical microbiology innovation to think about that. The Danish Technical University is creating some panels and offering those, but there are not a lot of options. We're taking advantage of the options that are there. And this is a space that people could really move into, particularly on the genomic side. The good thing though is that quality assurance for genomic surveillance is actually easier than for basic microbiology. Referral, let me see. That's okay. Yes, Dana Itani, another question on actually, before I answer that question, I'm just going to ask Sophonias whether there's anything burning from the chat, because I noticed that we only have a few minutes left. If not, I'm happy to proceed.
I think if you can address, Prof, the last two questions that we have here on the Q&A.
Okay, thank you so much, Sophonias. Yes, referral system. I think one of the most important components of our surveillance system that's often overlooked is that you have to have a national coordinating center. You can't just have a group of motivated academics running a surveillance system. You have to have a national center in your Ministry of Health that coordinates the network. And so I wouldn't be telling you any of this if we were not working directly with NCDC. So NCDC is responsible for onboarding labs into the system, for communicating with labs for us. And the labs they're part of the Ministry of Health. They're organs of the Ministry of Health. So it's much easier for them to work with the National Center for Disease Control than Iruka Okeke, a professor in the University of Ibadan. So that being said, it's been a challenge. We're a new surveillance system. We're not used to being a surveillance system. NCDC sends out emails and we have to follow up with reminders. People send us things that are handwritten that should have come through HUNET. We're working with that. We're learning, we're growing, we're providing as much training and support as possible. It's not working smoothly now, but it is a work in progress. And there is, importantly, there's a system. We actually have a system that we're aspiring to and working towards. So the labs send in strains and information to the National Reference Lab at University College Hospital, and then they remit the information that we need to be able to provide the genomic services. Last question that I could answer is from Jeremiah Shaney or Sani, I'm not sure. Thanks a lot. How then do we leverage limited resources we have in Africa? Any plan to link up with other countries? Yes, we're completely linked up with other countries. I have actually met Sophonias before this talk. He's coordinating PGI. We're talking very closely to PGI. We are part of Seek Africa, and Africa CDC helps us with coordination within Seek Africa, which means that we offer genomic services for AMR for anybody on the continent that needs them, on a prioritized basis, of course. So if this is something that you need to Google Seek Africa, go to the site, download a form, fill the form. If you're in West Africa, it will probably come to us. If you're in East Africa, it will go to our colleagues in KCRI. If you're in Southern Africa, it will go to our colleagues at NICD in South Africa. And we will try and find a way to make it work. Ultimately, I think many more countries are going to onboard genomics. And I'm hoping that when they do so, they also use it for surveillance of antimicrobial resistance. Thank you.
Thank you so much, Professor Iruka, and thank you all participants for those questions. We didn't have time to go through all of the questions, but I think Professor Iruka addressed the key questions. I think I just want to say, the procurement issue, the supply chain issue, maybe we'll come back again with another session dedicated for that in this webinar series to discuss in more details. I know it's one of the burning issues that we all are facing in the continent. Otherwise, we are on top of the hour. Thank you so much, Professor Ruka, for this excellent presentation and for this interactive session and addressing most of the questions. So we will have this webinar series every 2 weeks. So we'll look forward all of you to join us again in 2 weeks' time for another topic which is related to policy in pathogen genomics. Thank you so much, and good afternoon, good evening, or good morning, wherever you are, and thank you so much. Over.